Welcome back to the deep dive. Today we're focusing on something that every surgeon, whether you're a trainee or an attending, needs to have a very clear mental checklist for.
Open right nephrectomy.
Exactly. We're going to really zero in on why operating on the right kidney is just a fundamentally different beast than operating on the left.
It is, and that distinction is critical. Our mission here is to really distill the key principles, the anatomy, the surgical choices, the oncologic thinking that are unique to the right side.
We're talking about the things that, can really keep you up at night.
IVC proximity, liver involvement, and that huge question of timing. When do you actually take that patient to the operating room?
Okay, so let's start with that blueprint. We all learn the embryology, the metanephric blastema, the ureteric bud, but
Yeah.
the real story is in how that ascent creates so much variability.
That remodeling process is everything, and it's exactly why you cannot, under any circumstances, skip rigorous preoperative imaging.
It's just non-negotiable.
Right, because that variability means you're going to see accessory renal arteries, or you're going to find multiple short veins. I mean, some studies show up to 30% of patients have some kind of accessory vessel.
And that's a third of your cases that are instantly more complicated.
Instantly.
So let's talk about the kidney's position. It sits a little lower on the right, tucked under the 12th rib, but it's the neighbors that really define the challenge.
Oh, absolutely. The local geography is everything. When you start to mobilize that right kidney, you're dealing with some serious structures.
Liver, first and foremost.
The liver is dominant. It's sitting right on top, creating Morrison's pouch. Then immediately you have the second part of the duodenum, which can be, paper thin.
And the colon wraps around the front.
The ascending colon and the hepatic flexure, yeah. And a big tumor just forces you to dissect right up against and sometimes into all of those.
But when you boil it all down, right versus left, what is the one vascular difference that just changes the entire operative game?
It has to be the right renal vein.
The length of it.
The length, or lack thereof. It's notoriously short. We're talking just a few centimeters sometimes. And it drains almost immediately and directly into the inferior vena cava.
So for every single right nephrectomy.
The IVC is immediately and profoundly at risk. It's right there in your field from the very beginning.
And that short vein changes everything. So if the vein is that short, what's the artery doing?
Well, the right renal artery is actually longer, but, and this is the crucial part, it runs posterior to the IVC.
Which makes getting control.
Much trickier. You need a deeper, more careful posterior dissection. You're often gently retracting the IVC to even find it, which is, a nerve-wracking maneuver.
And the smaller veins don't give you any help on the right side either, do they?
No, you don't get that nice long venous stump you sometimes get on the left. On the right, the adrenal vein and the canodal vein, they usually drain straight into the IVC.
So they're not tributaries of the renal vein.
Exactly. It's another reason why any little tear or avulsion near the hilum becomes a high-volume bleed directly from the IVC wall. The takeaway is inescapable. IVC proximity just dominates everything.
Okay, so with that anatomical danger zone in mind, how does the tumor itself, its size, its location, push you immediately toward an open approach over, say, a minimally invasive one?
It's all about complexity. If your pre-op imaging suggests any major vascular involvement, or if you're dealing with a massive tumor, something T3 or above, you're almost always thinking open transperitoneal surgery from the start.
You just need the exposure.
You need maximum exposure to manage the IVC. There's no substitute for it.
And in that open world, we have a few choices. Midline laparotomy, subcostal, the flank approach. When are you reaching for that big midline incision?
The midline is the workhorse for anything really complex. If you think the IVC is involved, you might need to do a multivisceral resection or for just enormous tumors. It gives you the best shot at proximal and distal IVC control.
What about a subcostal or chevron?
Also excellent. Really good for upper pole access. Gives you a great view of the liver bed.
Now, why do you get so cautious about the retroperitoneal flank approach for anything that looks malignant or complex? It sounds so appealing to stay out of the peritoneum.
It does sound appealing, but the problem is it severely limits your anterior exposure. It's great for a simple, small, benign kidney, an elective case.
But if things go wrong...
If you find unexpected adherence to the duodenum, or worse, if you need to clamp and repair the IVC, you just don't have the room, you don't have the angles. The need for vascular contingency planning just pushes you toward that open transperitoneal approach.
Let's pivot to the oncologic side of this, cytoreductive nephrectomy. We've seen a complete paradigm shift here. It's not the automatic default anymore.
Not at all. The game has just fundamentally changed because of systemic therapies. Today, a patient presents with metastatic RCC, and the first move is almost always medical treatment.
Immunotherapy, TKIs.
Immunotherapy, often with a tyrosine kinase inhibitor, yeah. We treat them first, and then we reassess.
So delayed cytoreductive nephrectomy is now for a very select group of patients.
Very select. We reserve it for patients who have an exceptional response to the systemic therapy, who have a low burden of metastatic disease, and critically, who have a great performance status.
It's a calculated risk.
It's a very calculated decision. The patient has to be fit enough, and you have to believe the surgery will actually add to their durable disease control.
And this brings us right back to the anatomy of the right side. Those unique risks can actually tip the scales away from even considering upfront surgery.
Absolutely. If you have a right-sided tumor with clear IVC invasion, or maybe it's stuck to the liver and you're planning a massive resection, that carries huge surgical morbidity.
And that risk changes the calculation.
It reinforces the decision to start with systemic therapy. Why risk a massive, complicated operation on a high-risk patient when the medical treatment might shrink everything down and make a delayed surgery much, much safer? The tumor's address on the right side really makes you pause.
That caution is so justified.
Yeah.
I mean, let's talk about the specifics of that reticular dissection. That IVC's proximity is a huge psychological hurdle.
It should be. The challenge is instant. That short vein means your margin for error is, well, it's basically zero. The IVC is right there, poster immediately, and you always have to remember that artery is hiding behind it.
And it's not just the big vessels. You have those little bleeders that could obscure everything.
Precisely. The lumbar veins, the adrenal vein, they can be the source of that troublesome bleeding that turns a clean dissection into a frantic search. Controlling those tributaries early is just so important.
But the strategy completely transforms when you find actual IVC wall invasion or a tumor thrombus.
Right. At that moment, it stops being just a nephrectomy.
It becomes a vascular operation.
It becomes a vascular operation that just happens to involve removing a kidney, and that requires a totally different level of preparation.
You need the right gear in the room.
You need it immediately available. Vascular instrument, sets your Satinsky clamps, your bulldogs. You need a cell saver running. And you have to have a pre-established plan for IVC control, proximal and distal, because if you get into it, you lose control in seconds.
So you're calling vascular surgery early.
The moment you suspect a significant thrombus on the scan, you should be having a conversation with your vascular colleagues.
Let's talk about when the tumor involves the neighbors. What are the common end block resections on the right?
The top concern is always the liver, specifically the posterior segments, 6 and 7, which are right up against the upper pole. You may need to take a sliver of the liver capsule or even a full wedge resection to get clean margins.
Which adds a ton of morbidity.
A huge amount.
And the bowel.
An aggressive tumor can grow right into the ascending colon or the hepatic flexure. If it's invading the mesocolon or the bowel wall, you're doing an end block colectomy.
And the really scary one.
Direct invasion of the duodenum. It's rare, but it is an absolute nightmare. If you see that on imaging, you need a plan that involves your GI or HPV surgical colleagues from the very beginning.
And the principle is always the same, no matter the organ.
Always end block resection.
You can't just shell it off.
Never. You never try to shell or peel a tumor off an invaded organ. That's a guaranteed positive margin. The question you have to ask is whether the risk of that multivisceral resection is justified by the oncologic benefit. That's a tumor board discussion every time.
Given all this, let's wrap up with the complications we're trying to prevent. What's the hierarchy of what surgeons fear most during a right nephrectomy?
The hierarchy is crystal clear. At the very top is major hemorrhage from an IVC injury. The blood loss can be catastrophic and instantaneous.
Right below that.
Hepatic injury, either from difficult retraction or direct mobilization, then duodenal or pancreatic injury. And something people forget because of how high that kidney sits, a pleural breach. A pneumothorax.
So how do you prepare for that moment, the one where things go wrong and the IVC is torn?
Preparation is everything. It starts with just meticulously reviewing that pre-op CT angiogram, mapping every single branch.
Then in the OR.
In the OR, you need good access, warmed fluids, a cell saver that's primed and ready, and those vascular clamps on the table, not in the cabinet down the hall.
It's about being able to get control quickly.
It's the difference between a controlled crisis and a complete catastrophe. Rapidly securing the IVC, proximal and distal to the injury, that's the whole ballgame.
What are the key technical moves for just ensuring a safe operation from the start?
Exposure, exposure, exposure. You cannot be stingy with your incision. The key maneuvers are mobilizing the liver to see the IVC above the renal veins and fully medializing the right colon to open up that entire retroperitoneum.
See everything before you touch anything.
Identify all your landmarks, IVC, aorta, duodenum, before a single clamp is thrown. It's that cautious, deliberate control of the small vessels that lets you finally deal with the main renal vein safely.
Which really speaks to the need for a multidisciplinary team for these complex cases. You can't be a lone wolf.
That's the modern standard of care. For an extensive IVC thrombus, you need vascular, maybe hepatobiliary surgeons, and a dedicated critical care team involved from day one. Your contingency plan has to include having grafts or patches immediately available for IVC reconstruction. It's a full team sport. #outro.
That really wraps up our deep dive. The critical takeaway here seems to be that the right side is entirely defined by that short renal vein and its intimate relationship with the IVC.
That's it. It demands specific technical strategies, a different level of preparation, and a really careful thought about timing, especially in metastatic disease. If you're going into this case, you have to appreciate that the major variables are almost all venous. You're managing the largest vein in the body.
So here's the final thought for you, the person planning for this operation. Given that risk of IVC involvement, hepatic injury, and the potential need for multivisceral resection, this complexity really highlights why a personalized approach and robust contingency planning have to trump any kind of standardized technique.
No two are the same.
Right. So when you're planning your case, you have to ask yourself one question. If I tear the IVC right now, do I have the hands, the instruments, and the exposure to fix it? That question should guide your entire approach.